Department of Pediatric Gastroenterology at Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow, India. He has several publications, and most of which are international ones. He is also a reviewer of 26 journals and associate editor of Frontiers Pediatric Journal and a section editor of Indian Pediatrics Journal. He is also ranked as one of the world's top 2% scientists in 2021. Today, he is going to give us a talk on endoscopic management of upper GI bleeding, both variceal and non-variceal. Please welcome Dr. Poddar.
Let me start with a big, great thanks to Dr. Pukara Paul, Chair of the organizing committee, and Professor Supan, President of APPSGHAN, for giving me this opportunity to be involved in the first endoscopy masterclass of our society APPSGHAN. I'm going to talk about endoscopic management or upper GI bleeding, both variceal and non-variceal. This is for those who have not already read it. I will suggest to read this free article. It is the PubMed free download. Most of the thing which I am going to discuss is given in this article. Traditionally, what we call is upper GI bleeding means the source of bleeding is proximal to the ligament of trees. It is the arbitrary line which is dividing the duodenum and jejunum. So what are the organs from where the upper GI bleed can happen? Esophagus, stomach, duodenum. Uncommonly, pancreas may be the source of bleeding, like a pseudoaneurysm rupturing into the pseudocyst and coming out to the papilla. We call it hemosarcus pancreaticus. There may be a case where there may be a trauma to the bile duct or liver and causing bleeding through the bile duct and coming to the papilla into the duodenum is the cause of upper GI bleed. We call it hemophilia. Now, first and foremost thing as an endoscopist, we have to determine is this bleeding clinically significant or not. We call it major bleed or clinically significant bleed, but this is the subset of patient we need to do urgent endoscopy and take the therapeutic action. So any of these features, when there is a hemodynamic instability, fall in hemoglobin more than 2 grams, or requirement blood transfusion, we qualify as clinically significant or major bleed. If none is there, then we call it minor bleed, we can relax. Now, how do they present? The commonly, presentation depends on the site of bleeding, etiology of bleeding, and the rate at which it is bleeding. Commonest presentation is hematemesis, meaning vomiting blood, which may be bright red or coffee ground. Bright red indicates the brisk bleeding. When it is an altered coffee ground, means it is a slow bleeding mixing with food and coming out. It may be the quantity may be small or large. It may contain clots. Clots means 1 fistful of clots signify 500 ml of blood, so indicates the massive bleeding. Second most important presentation is melena, black tarry stool, and as you know, to produce melena, you need to have at least 60 ml of blood stays in the intestine for 6 hours, then only it becomes melenic stool. If a child comes with history of hematemesis but no melena, that signifies bleeding is not significant. Hematochezia means bright red blood per rectum. Common notion says that hematochezia means lower GI bleed. However, out of all hematochezia patients, 10% are due to upper GI bleed. You know, the blood is a cathartic. When it enters the small intestine, it hastens the movement, and without changing to the black color, the blood may come out as such, and then that is a reason for hematochezia as a presentation of upper GI bleed. Rarely you can get a patient of occult bleeding. Occult bleeding means you don't see the blood. Only on investigation like stool occult blood is positive. And obscure GI bleeding means when both upper GI endoscopy and colonoscopy done, cause not found, that is called obscure GI bleeding. Now I have quoted these 4 studies to find out what are the common etiologies of upper GI bleed. There is difference between the East and West. The developing countries, we get more often variceal bleed as a cause of upper GI bleed. On the contrary, the studies from America have shown these are mainly peptic ulcer disease, gastritis, esophagitis. Why is so different? This difference. Predominantly in developing countries, we get to see an entity called extrahepatic portal venous obstruction. That is one of the commonest cause of varicose bleeding. And secondly, the age group. These two studies, as when the age group as a pediatric age group taken as 12 years, but in the American, Europe, their studies, they have taken up to 18 years, 17 years. You know, the adolescent, they are prone to develop peptic ulcer. They are on non-steroidal anti-inflammatory drugs, so they can have drug-induced gastritis, esophagitis. And that's why there is a difference between the etiology of upper GI bleeding between East and West. Now, if you talk about portal hypertension, this is a big study we have published from Chandigarh. When a patient comes with variceal bleeding, it is commonest cause is extrahepatic portal venous obstruction. But when you are doing endoscopy to look for varices, not blade, then cirrhosis is the commonest cause. Clinical approach, the assessment of severity is the most important. The first slide I said you have to decide is it clinically significant or major bleed or it is a minor bleed. So that start with the history. You get the history of hematemesis. You can ask the quantity of blood, color, as I said, the bright red color versus altered blood or associated clots. Melena, hematochezia will suggest there is significant bleeding. Postural symptoms, very important. Patients may not come out with this history of blood transfusion or drop in hemoglobin, but if the patient develop postural symptom, means giddiness, perspiration on changing posture, that indicate there is a significant bleeding. Obviously, requirement of blood transfusion signifies major bleeding. While examining the patient, we need to pay attention to the hemodynamics, especially the pulse and blood pressure. A patient may not have tachycardia or hypotension, but we need to check the postural drop. What will you do with postural checking of postural drop or blood pressure? Take the blood pressure and heart rate in supine position. Make the patient sitting, wait for 3 minutes, again check the blood pressure and heart rate. If there is drop of more than 10 millimeter of mercury of systolic blood pressure, that signifies there is a significant amount of blood loss, at least 10 to 20% blood loss, and that will be taken as major bleeding. While taking history, we can get some idea about the etiology of GI bleeding. If there is a history of drug ingestion like NSAID, obviously you think about ulcer disease, sick child in ICU setting, stress ulcer bleed. If there is preceding history of dyspeptic syndrome, you think about peptic ulcer disease. If there is a history of vigorous retching with vomiting followed by bleeding, then you think about malarious tear. If there is a past history of liver disease or portal hypertension, obviously that signifies variceal bleeding. But the most important is how the patient tolerated bleed. After a significant or massive upper GI bleed, if the patient is not developing ascites, encephalopathy, or apparent coagulopathy, that indicates the patient has tolerated bleed well. So that goes against a diagnosis of cirrhosis, indicates non-cirrhotic portal hypertension. In the examination, we look for the peripheral stigmata of chronic liver disease, bleeding from other side like mucocutaneous bleeding in coagulopathy or thrombocytopenia. We should look for cutaneous hemangioma. In children, there may be a congenital vascular malformation that may be the cause of bleeding. And most important examination finding in a patient of upper GI bleed is presence or absence of splenomegaly. It has been shown that portal hypertension bleeding, 95% cases you get splenomegaly. On the contrary, splenomegaly is in just 5% cases where the bleeding is not due to portal hypertension. So finding spleen is very important, and obviously you have to look for how big is the liver and there is ascites or not. Now, we'll utilize this information which I have provided to make a flowchart or algorithm, and let's see where we can go. And it is very simple, very useful in your day-to-day practice. The patient has come with upper GI bleed. First and foremost thing, is it a major bleed, clinically significant or not, with hemodynamic instability, or it is a minor bleed? As an endoscopist, you want the first group, major bleeding. If it is a major bleeding, is it a massive, painless with splenomegaly, or this is massive but no splenomegaly? I showed you the 95% chance of portal hypertension bleed will have splenomegaly. So if it is a first group, patient has painless massive bleed with splenomegaly, looks like a variceal bleeding, then what is the behavior of the patient after bleed? Has he tolerated bleed well? He has not developed encephalopathy or ascites, or patient developed decompensation. He developed ascites, encephalopathy. The first group, obviously, when the patient is having painless, massive bleeding with splenomegaly, tolerated bleed very well, then it is a non-cirrhotic portal hypertension. And in our setting, extrahepatic portal venous obstruction will be the commonest. However, if the patient decompensate after bleeding, means his liver is borderline function and decompensated because of bleeding, then it is a cirrhotic cause of portal hypertension. Second group, the massive bleeding, but you didn't get any spleen, though that can happen up in a portal hypertension in 5% of the cases. But in general, when there is no spleen, massive bleed, and after resuscitation also spleen is not palpable, then you have to look for, is it painful or it is a painless. If it is a painful, then obviously massive bleed, no splenomegaly with preceding history of pain is a peptic ulcer disease. Without pain, massive bleed, no splenomegaly, you have to think about vascular malformation. Minor bleed, obviously, you think about esophagitis, gastritis. See, these are all simple clinical tips and weights you can use to reach a syndromal diagnosis. Let's go to the approach. Fundamental clinical principle of managing GI bleed is immediate assessment for severity and the possible cause, which I have given you the clue how you can reach up to the level of syndromal diagnosis, and you start stabilizing the patient hemodynamically. Both should go hand in hand. You cannot wait taking detailed history and examination and wait for the patient to get collapse. You need to start if in a major bleed, that whiteboard cannula with colloid. Goal is to restore the hemodynamics. Now there is controversy about the putting Riles tube and doing the lavage. In adult studies have shown randomized control trial, there is no difference of putting Riles tube or not as far as the rebleed or out mortality is concerned. However, as a pediatrician, I will recommend to put a Riles tube. It gives three important pieces of information. First and foremost, is the bleeding ongoing or it has stopped? If you do the lavage, initially there is a red color blood, then it becomes clean. That means bleeding has stopped. That is reassuring. Second, while doing lavage, you remove the blood and clot from the stomach. That will help you further endoscopic visualization of the site of bleeding. And another important finding is that when the rise to lavage is showing bilious aspirate, that is reassuring that upper GI is not the cause of bleeding, or whatever is the cause of bleeding has stopped. Blood transfusion, obviously, when the patient is hemodynamic and unstable despite colloid, you give blood, continuous bleeding, you give blood. But the most importantly, a stable patient, when to give blood transfusion. Universally, it has been recommended whether it is a variceal bleed or non-variceal ulcer bleed, your target hemoglobin is 7. You have to be restrictive as far as blood transfusion is concerned. You cannot use the liberal transfusion that you give the blood transfusion up to 10 grams. Your target is 7. If you give the too much of transfusion, that will increase the blood volume, increase the portal pressure, and the more chance of rebleeding. So we have to be very careful about deciding blood transfusion. Less than 7, give transfusion, and target is around 7. Variceal bleed, obviously, you start the vasoactive drug, you have to try it, and ulcer bleed, you start PPI. Following hemodynamic instability, here comes the role of endoscopies. When to take the patient for endoscopy. In a variceal bleed, when you are suspecting, you have to do endoscopy within 12 hours of presentation, and in non-variceal, it is 24 hours. Endoscopy is the most important investigation to finding the cause, and obviously, you can do therapy in most of the cases of upper GI bleeding. Remember, the yield of endoscopy in major bleed is almost more than 90%, but in minor bleed, it depends on when are you doing endoscopy. If you do endoscopy within 24 hours of onset, 80% cases you will get a cause. But if you delay the endoscopy in a minor bleed more than 48 hours, it becomes less than 40%. You know why? That is because in the minor bleed, what is the etiology? It could be either gastric erosion or something like that, the superficial lesion, and cell turnover time in stomach is 48 hours. So if you delay it more than 48 hours, those superficial lesion will heal and you will not get any endoscopic finding. Now let's start with a case. This 8-year-old boy presented with recurrent episode of painless massive upper GI bleed for the last 3 years. There is no decompensation. He was tolerating bleed very well. On examination, besides pallor and tachycardia, he had a big spleen. So diagnosis, what the algorithm I showed, this is a massive, painless, no decompensation with splenomegaly. So obviously variceal bleed and tolerating well means this is a non-cirrhotic. So in our setting, we thought extrahepatic portal venous obstruction is the likely cause. Endoscopy showed this big varices with red color signs. So there is no doubt this is the source of bleeding. So what option we have? Either we can do band ligation or sclerotherapy. Obviously, endoscopic band ligation is preferred because it takes fewer sessions to eradicate varix and less complication. However, in pediatric practice, there is limitation. The smaller kid, less than 10 kilo or 1 year or 2 years of age, when you put the band on the endoscope, become bigger. You cannot push that mounted, good mounted endoscope to a smaller kid. So we have to rely on sclerotherapy for infants to control these varices. Sometimes you get the gastric varices as a cause of bleed, so less common, 10 to 20% of all varicose bleed is because of gastric varicose bleed. We can inject uh, tissue glue to control the gastric variceal bleeding. Other option of controlling gastric variceal bleeding, endosono-guided glue and coil injection. You can take the help of radiologists to do the BRTO, balloon occluded retrograde transvenous occlusion of the obliteration of the varix. We can go for TIPS, transjugular intrahepatic photosystem shunt, or non-synetic development. Now, this is the latest guideline given by the WABNO 7 in the April 2022 approach to variceal bleeding. All patients should be started on vasoactive drug. We use the octreotide and transfusion when the hemoglobin is less than 7. After stabilization, endoscopy done within 12 hours and endotherapy will be started. Now, when you do the band ligation and start vasoactive drug, 80 to 90% cases bleeding will be controlled, and subsequently patient will need secondary prophylaxis till eradication of the varices. But in 10 to 20% cases, the failure of endoscopic therapy. So what options we have? In emergency, we can use the balloon tamponade or self-expanding metallic stent fully covered to control this emergency bleeding. The high-risk patient of recurrence. What is this high-risk group? In adults, they say that there is a child C cirrhosis with a variceal bleed, or child B with active bleeding during endoscopy, or patient had very high HBPG, hepatic venous pressure gradient more than 20. They have a high risk of rebleed and death. So they recommend upfront tips. You go for tips instead of going for subsequent endoscopic therapy, transjugular intrahepatic photosystem shunt within 72 hours, preferably within 24 hours, and that has got survival benefit and less recurrence. This is the Sengstaken Blackmore tube. We don't use often. It is a very useful in controlling refractory bleeding. Efficacy is 90%. However, it's a very high complication rate. 60% patient develop fatal complication, maybe fatal aspiration, perforation. You can keep it only for 24 hours and rebleed is 50%. This is a special stent developed to control variceal bleeding. It's called the Dennis Ella stent. It is very successful in controlling refractory bleeding, can be kept up to 7 days, fewer side effects, unlike second Blackmore tube, but risk of stent migration is high. But the biggest problem for our pediatric gastroenterologists, this is designed to be used for 16 years or above. We cannot use in smaller kids. Second case is a known patient of juvenile rheumatoid arthritis on non-steroidal anti-inflammatory drug. He presented with pain abdomen followed by upper GI bleed, no decompensation, there is no splenomegaly. Obviously, the suspicion was it is an ulcer bleed. In duodenal ulcer bleed, endoscopy plays an important role to decide whether you need to do any endoscopic therapy. Like in variceal bleed, we said that sclerotherapy or band ligation, here therapy is different, but not all patients of duodenal ulcer require therapy. We apply this forest classification to decide what the high risk stigmata of recurrence of bleed. If you don't do endotherapy, they will have a rebleed and risk of death. The first three, forest 1A when there is sputter, 1B when there is a oozing along with ulcer, and visible vessel. These are the three who requires endotherapy. Other three, like when there is adherent clot or flat pigmented base or clean base, they don't need endoscopic therapy. Now, besides those endoscopic stigmata, people have shown if the ulcer is large ulcer, more than 2 centimeter or more than 3 centimeter, sitting on the posterior wall of the duodenum where there is a the artery, ulcer is over that, or high laser curvature, they have a high risk of rebleed and require therapy. So this is the American College of Gastroenterology clinical guideline 2021 about this ulcer bleed. Choice of endoscopic therapy. What therapy we can? It should be combination. We cannot use the adrenaline injection alone. In addition to adrenaline, you have to use the thermal contact devices like heater probe or electrocoagulation. But more recently, mechanical devices like hemoclip is very useful in controlling bleeding. Over the scope clip is a big over the scope clip, become 14.5 millimeter. We cannot use a smaller kit, but it is useful when there is a recurrence of bleeding after previously successful endoscopic hemostasis. Hemospray is available in some of the countries. It is a temporizing method. It lasts only for 24 hours. You have to use definitive therapy after that. Ulcer with high risk stigmata following endoscopy, you need to give high dose PPI intravenous for 72 hours, twice daily for 14 days, and then once daily. A few tips about using hemoclip. You remember I showed that picture of visible vessel. The visible vessel is the source of bleeding, but it is fed by there is a feeder artery. So what you need to control? You have to clip the feeder artery. So the trick is that you have to apply clip both proximally and distal to the visible vessel, not attacking the visible vessel itself. Now, what is the approach? Endoscopy you do and find there is an ulcer with active bleeding or visible vessel, adherent clot, or there is a flat pigmented base or clear base. The first group, obviously, after vigorous irrigation, adherent clot can go become visible vessel or pigmented base. Endoscopic therapy is required only in the first group, actively bleeding or visible vessel, and followed by high dose PPI, adherent clot. There is no benefit of endoscopic therapy, only high dose PPI, flat pigmented or clean base, no endoscopic therapy, standard. Third case, 9 years old boy presented with vomiting with vigorous retching for 3 days. He was having vomiting without blood. He was taking out whatever he has eaten, but he has associated retching. On the third day, he started having hematemesis with retrosternal pain. He was pale, tachycardia, but there is no organ, no splenomegaly, except the mild epigastric tenderness. So what is the diagnosis? If you apply this algorithm which I have shown, it looks like he has a retching with vomiting, but it was a massive bleed, some pain, but no splenomegaly. So it looks like this child has malarious tear. So how do you diagnose malarious tear? Malarious tear is a tear at the gastroesophageal mucosa of gastroesophageal junction. So go to the stomach, retrovert the scope, you can see the tear. So it is an uncommon cause of non-variceal bleeding. It has been shown in 3% adult cases of all non-variceal bleed. And in a pediatric study of 2,700 upper GI endoscopies from Poland, 0.3% had malarious tear. What treatment option? It is like a ulcer. If there is a on active bleeding or visible vessel, you use the hemostatic technique. You use the hemoclip, you can use band ligation or injection, and efficacy is 90%. The last case is a 12 years old girl who presented with massive upper GI hematemesis for 1 day, no history of preceding pain. She never took any drugs to produce ulcer, no systemic illness. She was having significant pallor, hypotension, no cutaneous hemangioma to suggest this congenital vascular malformation, and no splenomegaly either. So in that algorithm, she had a painless, massive upper GI. However, there is no splenomegaly and there is no decompensation. So it looks like he has some vascular malformation. Endoscopic picture, there is a sputter from a minute lesion. It's not visible at all. So this is a developed lesion. Uncommon cause of massive upper GI bleed, but it is seen in children as well as in adult, and it can be seen in throughout GIT, but mainly it is in the stomach. This what is this? This is a congenital malformation due to presence of a large caliber arteriole in the submucosa. This artery is not going to join a capillary, so constant pressure, this thinning of the walling mucosa, it starts bleeding. So there is 30 cases reported so far in children. Fortunately, 70% of them are stomach. You can have the airway pullopoid also, but it's predominantly in the stomach, and majority are in the proximal stomach. So what option we have? Diagnosis is endoscopy is the most useful because 70% are in the stomach. You get a minute mucosal defect with parting or protruding vessel or pulsating vessel. What treatment? We can use the endoscopic therapy effectively. More than 90% cases is successful if you are remotely or band ligation, and surgery when both endoscopic therapy and radiological intervention fail. So to conclude, variceal bleeding is a common cause of major upper GI bleeding in developing countries because we see many extrahepatic proteinomas of them. So in variceal bleeding, after resuscitation, endoscopy needs to be done within 12 hours, and obviously band ligation is preferred for sclerotherapy. Ulcer bleeding with a high risk endoscopic stigmata means when you have an ulcer with sparter, oozing, or visible vessel, they need to be tackled with endoscopic therapy. And what endoscopic therapy? Combination of adrenal injection and one of the contact devices or hemoclip. Endotherapy is effective in other uncommon causes like malarial tear and developers lesion as well. Thanks for your patience here.